my proud privilege to invite yet another global expert in the field of endoscopy, Dr. Nageshwar Reddy, a name synonymous with development in the field of endoscopy, not only India, but worldwide. He is a very keen researcher and has published more than 600 scientific papers in the peer-reviewed journals, and he can be named as a man of endoscopy in our circumstances. Need not to explain all about his achievements. He has won the hearts of all the people all over India and all the endoscopists. May I now invite Dr. Nageshwar Reddy to present his Nageshwar Reddy.
Thank you very much, Ramesh, and thank you for this kind introduction. Of course, many of these have been recorded, but mine is going to be live, so hopefully there won't be any glitches, because yesterday when I was speaking with Manoj and Mamta, the event managers, they told me that they prefer to have recorded version because then there's no problems. But my talk is going to be live because the problem is I was in Bhubaneswar yesterday and only came back today. So my talk is on EU-RCP in CP, and in fact I was asking Avinash, how did you get this topic, and he told me that this is indication that you have US and ERCP in CP, and this is what probably the meaning was. He saw it in a German conference. He said, can it be used in patients with chronic pancreatitis? So I thought over it a little and said, okay, let's see how we can apply endoscopic ultrasound and ERCP in patients with chronic pancreatitis. Basically, the treatment of chronic pancreatitis is to treat the pain in these patients. That's the only treatment. We can't treat malabsorption, we can't treat diabetes and so on with any endoscopy or surgery. It's only pain. And we have actually published a pathophysiology of how pain occurs in these patients. In 2/3 of the patients is because of ductal hypertension. And rest 1/3 is because of oxidative stress, local inflammation, which we cannot alter by endoscopy. The only thing we can do by endoscopy is decrease the ductal pressure. And this ductal pressure increases because of strictures or stones, which can cause this. And endoscopy and surgery aim at decreasing this pressure, hopefully, therefore, decompressing the duct and also partly improving the functions. And this is very difficult surgically. And this is Dr. G.B. Rao's slides who gave to me, that even at surgery, these stones are very difficult to pick up from chronic pancreatitis patients. So we have now, of course, do an extracorporeal shock wave lithotripsy, and these stones can be blasted into small bits, and then they can be completely cleared. Based on this, actually based on most of our studies, the ESGE has recommended that in patients who have stones of more than 5 millimeters in the main pancreatic duct, which are radiopaque, one should do an extracorporeal shock lithotripsy followed by extraction rather than going for surgery first. And of course, there are some controversies in this area I won't go into, but this is what we would suggest. Now, there are several factors which determine how successful we are. It depends on the stone size, presence of strictures, duration of disease, and use of narcotics. Of course, the other subtle things are operator experience, type of lithotripsy, and use of secretome. In fact, there are 3 important things that are responsible for effective stone breakage. One, of course, is the machine. You have to have a very specialized machine. There are only 3 available for this particular purpose. You have to have an operator who's got passion about breaking the stones, because this can be a boring job. And we have somebody here, Dr. Vinod, only doing this the whole morning to evening. And of course, use of epidural anesthesia, so the patient control his breathing also helps. So we don't use propofol or other forms of sedation, but epidural anesthesia. So a combination of these 3 can result in very positive success rates, breaking these stones into small powder like this, so the duct is completely cleared, and you can see the effect pre and post ESWL. Of course, sometimes even without endoscopy, if you can actually fragment the stones into very small bits like this, you can clear the duct. And this was a study from Jack Davies' unit. There's now a tendency to try and do intraductal pancreaticoscopy and break these stones, either using EHL. When you have very good view like this, the stones can be fragmented, or also there is some evidence that you can do it with laser spike cholangioscopy. But whatever method you use, success is the ultimate thing to clear the duct. And we found that ESWL is much superior to intraductal pancreaticoscopy. And this is actually the world's largest series published by my colleague Manu Tandon in pancreatology, where 5,000 patients had almost complete clearance in 72%, partial clearance in 17%. So over 90% of the patients, we could clear the stones completely with effective therapy. Yeah. So the effective therapy is when, in fact, this is a study which came from UPenn, David Whitcomb's unit, which actually looked at those who are responses versus no responses. And what they found is that endoscopic therapy is effective. The stones are in the head. The disease duration is less than 5 years. If the pain is intermittent, there's no narcotic use, and patients are not smokers or alcoholics. Just remember this group of patients, they're the ones who will respond to endoscopic therapy. But what about long-term therapy? Because surgery is all about long-term therapy. Is endoscopy as effective as long-term as surgery? And this is the first study that came on long-term therapy way back from Jack Davies' unit, which showed that even after 11 years in a large cohort of patients that they had treated earlier, even after 11 years, their pain and stent exchange phenomena suggested that this was quite effective therapy. Another study which came from the Kozarek unit showed similar features, but we also looked at our large cohort of patients. Again, you can see Manu was the first author for this. We looked at intermediate follow-up for 2 to 5 years, long-term follow-up for 5 to 8 years, and found that in majority of these patients, pain relief and need for reintervention remained for very, very long term. So I think this is very positive. And those patients who had stone recurrence, 14 or 20%, 20% only after 10 years, you could still treat them endoscopically. So there's a big debate. I don't want to go into this. Endoscopy versus surgery for painful chronic pancreatitis. We actually did an editorial on this, how we should look at it. We believe that if there are any stones in the head, dilated duct, endoscopy therapy is useful. Stones everywhere, no, dilated duct, still you could do endoscopic therapy. But if you have stones like this with chain of leg appearance with strictures, these patients should go primarily for surgery. The other cause of pain, if you remember, we thought of strictures, and strictures are treated with stents. The way we stent these patients has changed now. We now tend to use multiple stents after balloon dilating, 3 to 4 stents, a concept that Guido Costa Magna actually advocated. We use multiple stents, stent for more than 1 year, and then remove the stents. And then this is, again, very effective methods. We're trying to now change to see if we can use a completely covered stents. And a recent study that we did with the prototype stent suggested that using a completely covered self-expanding metal stents may be as good as using multiple plastic stents. Now let's come to the second part, which is endoscopic ultrasound. What is the role of endoscopic ultrasound in this feature? Because from what I told you, ERCP and endoscopy is quite effective in treating these patients and combined with extracorporeal shock to lithotripsy. But there are a group of patients in whom endoscopic ultrasound may be needed either for diagnostic purposes or for therapeutic process. The reason why endoscopic ultrasound is particularly useful for pancreas is because endoscopic ultrasound probe is very close to the pancreas. Ability to image the pancreas is unmatched by other imaging modalities in this situation. And this was a very old study which actually showed that if we look at the sensitivity of EUS, you can see much higher than other modalities. The specificity also is very good. So among all the modalities to test for chronic pancreatitis, especially early chronic pancreatitis, endoscopic ultrasound is superior. Sometimes it may be too sensitive also, and many subtle changes are seen here. Heterogeneity with lobulation, dilated duct with thickened walls, and of course calculi in the duct. All this would suggest that you're dealing with a chronic pancreatitis patient. There have been several criteria, started from Chicago criteria to Rosban criteria, which would suggest that you're dealing with a chronic pancreatitis, and especially in early case when plain X-ray, CT scan or MRCP are normal or near normal, then presence of hyperechoic foci, hyperechoic strands, lobularity and cysts, and of course calcification, hyperechoic PD margins, irregular PD contour are all suggestive of chronic pancreatitis, especially early chronic pancreatitis. So once we diagnose chronic pancreatitis, we know that diagnosis of chronic pancreatitis is best done by standard techniques. But in some cases, very early cases, of course, we use an endoscopic ultrasound guidance to diagnose it. There is one criticism here that sometimes endoscopic ultrasound may overdiagnose chronic pancreatitis. That subtle changes which may occur even after recovery from acute pancreatitis or be related to age or diabetes can sometimes give a wrong appearance of chronic pancreatitis. So one should be aware of this when you're using this as a diagnostic modality. Now, endoscopic ultrasound is also extremely useful for EUS-guided PD drainage, which is, of course, our aim of treatment in this patient. Now, why do you require EUS and not ERCP? The reason is that either the papilla is not accessible, or you can't pass a guide wire through the stones which are there, or there's a post-operative situation where you don't have a papilla at all. In all these situations, you can use an endoscopic ultrasound-guided PD drainage. This, of course, requires a little... So ERCP is the mainstay with high success rate, but sometimes you can't access, and then you require an endoscopic ultrasound. The first case report of US-guided pancreaticography was actually very, very long back. This was which was published by Pierre Desprez when he used this technique where using endoscopic ultrasound, he did a main pancreatic duct drainage, and then of course continued with an ERCP in this case to completely drain the duct. So this was reported very, very long back. And this is what now we are starting to use more and often. So the main indications for using endoscopic ultrasound in pancreatic ductal drainage is failed ERCP in patients with obstructive chronic pancreatitis, disconnected pancreatic duct, inaccessible ampulla, post-surgical altered anatomy, and of course when an ampulectomy is done and a prophylactic stent is couldn't be passed, the duct then dilates and then you go in. There are contraindications, and the most important contraindication when using an endoscopic ultrasound, even before attempting it, is that if you don't have a dilated duct, you should not think of using it at all. When the multifocal pancreatic duct strictures, an EUS is not a good method. And of course, there's a long distance from the GI wall to the PD. You must remember the pancreatic parenchyma is very tough in these patients. Fibrotic, calcific, and getting in may be difficult enough. Especially if you use a Doppler and find a large vessel, then this should not be used. Relative indications are the use of anticoagulants, and I would suggest that anybody with an INR of above 1.5 and definitely 2 or low platelet count should not have these procedures, as we have had major bleeds in these patients. There are 3 ways of actually draining the pancreatic duct by using endoscopic ultrasound. The first is, of course, the rendezvous technique we talked about, where you go into the stomach, pass a guide wire which comes out through the duodenum, and then later take an ERCP scope and finish the procedure. This is the first method. The second method, especially when patients who have had a Whipple surgery or some sort of surgery and you don't have a papilla to access, only the pancreatic duct is directly draining into this afferent limb. In these cases, of course, you can pass a wire across, either stent like this or even complete it with a rendezvous procedure. But a very, very commonly used procedure, and we'll come to this a little later, is transluminal or transmural antegrade approach only. So the stent is passed from the stomach into the pancreatic duct and left in place in the stomach. So this is what is being done. And of course, again, this is an example of how we do this technique. That is, the pancreatic duct is dilated here. You can see US needle quite clearly. And once it is in, we use the standard guide wire. We're now tending to use 025 guide wire and not 035 guide wire. And then following this, we put in these stents, which can, with some difficulty, get into the pancreatic duct. So there are a variety of accessories that have been used in this situation. Guide wires, needles, and all, which are very specific. I'll talk. Can you see it now moving? Specially designed plastic stent. Ramesh? Is it moving?
We can see now.
Okay, yeah. So there are, in general, we use the same accessories as we use for endoscopic ultrasound, but there are certain specially designed accessories, and one of this is something that I would recommend if you can get access to. This is the Itoi stent, which is very special for pancreatic duct draining from the stomach. So this stent has got several special features. It is much more stiffer than the standard one, which is single pigtail here and 2 flaps in this case. And initially, Itoi reported 8 patient success rate, but now they're routinely using this, and they have now over 100 cases where they have successfully used this particular stent. The problem with the standard ERCP stents when using these patients are they're soft, they're not so tapered, and they tend to buckle because the pancreatic parenchyma is very hard. Also, we cannot balloon dilate this parenchyma, so we use a cystotome to dilate it, and sometimes the stent doesn't pass through after that. These are some technical details, but I think there's some issue that has to be resolved, because the most challenging part of therapy in these patients is to dilate this very hard pancreatic tissue tract. It's very hard, difficult to dilate. Avoid side branches, so we have to be careful. We have to have a hydrophilic guide wire with usually angled so that it doesn't go into side branches. Sometimes crossing obstructions and strictures are not so easy because you don't have much hold on the guide wire, and changing the angle of the guide wire is not so easy, and very often we find this, the wire gets stripped of its superficial surface because of this. So we try to change the needle, not use a very sharp needle, the separate axis needle, but unfortunately this needle was very difficult to push into the pancreas. So therefore, for these reasons, I think this is not such an easy therapy and it requires considerable experience. Somebody like Matthew Phillips has done many cases, probably can do this. So this is the other technique that I was telling you about, that we, especially in a situation like this, once the wire is passed inside, we can occasionally dilate, but I generally don't recommend balloon dilatation unless it's a very short stricture, and then put in a stent following that. The rendezvous technique is, in my opinion, much more physiological. We would actually localize, you see a fairly big duct there, we can go into the duct, and this often happens when the patient has a very stenotic papillary orifice, you cannot get into it, or has multiple stones there, so that you cannot bypass and go through the ERCP route. In these cases, we would carefully delineate the pancreatic duct, and you can see once you are inside, you have to be very steady when injecting contrast. And once the contrast is injected, you can pass a guide wire. You can see the video now, Philip. Matthews is there?
Yes, it is now visible.
So you can see the guide wire. You can see the angle guide wire here. That's very important. Angle guide wire goes through the head region. And once it goes through the head region, you come out with your US scope, leave the guide wire in place, and then using the ERCP scope, you can actually pick up this guide wire. And then you can actually pass yours. You can see that we are passing. And you have to be very careful here, because this, I find that very often the guide wire slips. And when the guide wire slips, you can't repeat the procedure again, because these patients already have taken a long time. But once you can go successfully inside, identify this guide wire, we would then pick out the guide wire through the ERCP scope and then complete the procedure using this by putting in a stent and so on. On rare occasions, you can use this if you have a very long guide wire, 480, you can sometimes take it on both sides and then put your stent, because then you get enough force to even pass very difficult strictures. But you can see here, we are actually putting a balloon here, dilating the stricture, because we have a good access now with guide wire on both sides. And then once it's dilated, we can do a sweep, remove whatever is inside, and then put a stent in these cases. So this rendezvous is quite useful this way. And you can see sometimes you can actually pass a stent across from the other side. I'll just go fast through this slide so that again, you can see the guide wire forming a loop and going in, and then can be picked up, and then you can pass the stent. So this is a flow chart of experience from Michael Levy group from Mayo Clinic. And you can see this was the early experience which they reported, subsequently confirmed with a larger series in 45 patients with failed ERCP or a surgical altered anatomy. They could clinically succeed in 83% of the cases, I think, which is very good. 83% they could. So ERCP failed in this case, or they didn't have access to papillary opening. But yet with EUS, they could succeed. Serious adverse effects, events are seen only in a small percentage of these patients, and mostly they involve in form of a bleed or a small perforation which resolves spontaneously. And stent dysfunction occurred in some patients in whom stent was later replaced. So I think if ERCP could be done immediately, especially for a rendezvous procedure, then your success rates also increase. Again, this is from Itoi's group, who actually were the pioneers, and you can see that again the initial report, but now they have over 100 cases. their adverse events were a little more higher, but they reported even the smaller adverse events like abdominal pain and so on, and that's why it's much higher in this group. So I think in general, the technical success rates are reaching 80% in most of the cases, with adverse events which are reaching about 20%. Again, this is Michael Levy's group, and you can see that bleeding and perforation are the two major adverse events. In some people whom we can't drain but injected contrast, you can get fever, because contrast in the pancreatic duct is not as bad as contrast in the bile duct, but can still cause fever. Stent dysfunction and migration occurs in a certain percentage of patients, but this can be treated very easily. The Koreans have gone further. In fact, they're now starting to use a completely covered stent, transgastric PD stent. So from the stomach, it's going into the pancreatic duct. They use this very specialized, completely covered stent. Recent studies, they're smaller in diameter than the conventional stents, but recent studies suggest that they're quite effective, at least for a 6 months period. But again, I'd like to emphasize here again that treating patients with chronic pancreatitis in whom ERCP is failed by endoscopic ultrasound is technically demanding. It can be expensive because you have to use various types of guide wires. And of course, experience is limited. Most of the big centers like the Mayo or Itoi, or sometimes in our center, we have had some experience of, say, but numbers are not as large as you see in ERCP. ERCP, you can see we have a report of 5,000 cases, which can never be reached with the US. The other area where endoscopic ultrasound-guided therapy is used in chronic pancreatitis very rarely are, of course, in draining walled-off necrosis, which is not a subject for today, but also for celiac ganglion blocks. And this is something which is used rarely, usually only for malignancy, but sometimes in a small duct disease, we are desperate, patient has pain, we cannot do anything. In these situations, we can use, as you can see here, celiac plexus block we call, but now we're trying to do celiac ganglion blocks separately. If we can visualize the ganglion, some people can. This is a report where we compared the percutaneous older technique with US guided, and on a randomized study found that US guided was definitely superior, more than 80% compared to 30% percutaneous. So we would suggest that in a rare patient who requires celiac ganglion block, to do it endoscopic ultrasound guided. So coming to the final management of these patients, you can see management of chronic pancreatitis patients can be by two techniques. So one group advocates a step-up approach, the other group advocates individual approach, whether you use an ERCP or whether you use an endoscopic ultrasound. This is Pramod Garg's group who suggests that in patients with chronic pancreatitis, all the patients should be treated initially with non-invasive techniques like medications, analgesics, antioxidants. If there's no response, go for endoscopic therapy. If there's still no response, go for surgery. So this is the conventional step-up approach. The other group suggests that we should go for a specific treatment. And what is a specific treatment? For example, you have chronic pancreatitis with pain, dilated ducts. Don't waste time with medical treatment. Go directly for endoscopic therapy, either with or without ESWL, based upon your ability to remove these stones or the stricture putting in stents. But if the patient has a mass lesion along with chronic pancreatitis or multiple strictures, then again, don't wait for medical endoscopic therapy, go for surgery directly. Where if endoscopic therapy fails or medical therapy goes, you can think of surgery. In non-dilated duct, which is the biggest challenge for us, medical treatment, when it fails, the only option we have is celiac ganglion block. So this is the problem. But I think it's generally a teamwork between endoscopists, even among endoscopists, ERCPs, and endocrinologists, interventional radiologists, surgeon, and physician, all coming together. And finally, I think the term that Avinash was attracted to, EU-RCP, may come to be true in future because companies are now trying to make this scope where they can combine an endoscopic ultrasound and ERCP scope, where you can do an endoscopic ultrasound immediately using the side view function of the scope, do all the procedures like you do ERCP. And when this becomes a reality, I think this would be the scope we'd start to do our EU-RCP procedures in patients with chronic pancreatitis. Thank you for your kind attention.
Thank you, Dr. Reddy, for a very, very enlightening talk. And you have really made things so clear that how should one be approaching the chronic pancreatitis pain, and you have really highlighted that it is the obstruction clearance which is going to make a difference in the management and alleviating the pain. And the various techniques and this new technology, which is probably going to come up, the Medwiz technique, by which you can go through the US, come out of the papilla, and put in the stent, and various limitations which you have put forward. Thank you very much for putting up everything. My question is again to you is about the non-dilated duct patients, which are many of the chronic alcoholic pancreatitis patients have. Do you find celiac ganglion block as to be a very effective method, or?
Yeah. I think, Ramesh, that's a very important question, because the group of patients who come to us with chronic pancreatitis with non-dilated ducts are the most difficult ones to treat. Unfortunately, some of them have already started using opioids, makes it a little more difficult also to treat. Yes, now, in these cases, we try and avoid the celiac ganglion block because we know that this is a temporary phenomena only for 6 months, but there's this very small group of patients in whom they're so desperate for relief of pain that we use this celiac ganglion block at least temporarily to overcome this pain, and then started them on other therapies before pain comes back again. As I said, this is very disappointing. Initial technical success rate of celiac ganglion block is almost 80%, but 95% of these patients get back their pain by 6 months' time. In this group of patients, again, surgery is difficult because there's no duct to drain. And what our group now, especially led by G.V. Rao, they're doing a total pancreatectomy with auto islet transplantation. We have good experience with auto islet transplantation because our basic science lab can now culture these pancreatic islets, give them back to the surgeon. So they do a total pancreatectomy and they're doing auto islet transplantation. We have reported a series of cases with very good benefit in this group. So I think ultimately the answer for patients with severe pain, with the chronic pancreatitis, non-dilated ducts, when other modalities all fail, is a total pancreatectomy with a pancreatic islet cell transplantation.
And it's very, very heroic procedure, and probably many centers may not be able to do it.
I think. In fact, before we started doing it, we visited the University of Minnesota, where this procedure has been standardized by Donald Sutherland and others. So we did visit the center, looked at what they're doing, looked at the result. Their team came and spent time with us. They actually helped us to standardize the pancreatic islet cell cultures. So we require a combination of very good pancreatic surgeons and very good basic science lab to get this together. And because this is not available in most centers, this cannot be done, like you rightly said. But once we started doing this, we have been very fortunate that these patients can get good relief from their discomfort.
When you do, as you just mentioned, that by doing endotherapy, probably you are not able to control the metabolic part, and the main things which diabetes and other things cannot be controlled except the pain. And I think they need to be understood by every one of us that we have limitations, and we should go ahead.
I think that's an important point also. The only rider to this is recently we published a paper, Rupjyoti in our unit, looked at all the patients we did ESWL over the years and looked at those patients who did not undergo ESWL. This was very interesting. Only follow-up without ESWL endoscopy, and one group were all followed with ESWL endoscopy. Between both the groups, he found that in those in whom we did extracorporeal shockwave and endoscopy therapy, the progression of diabetes was not as much as in those who did not have this therapy. So
very important.
Yeah, although we can't reverse the diabetes, but at least we can halt the progression of diabetes using this technique.
Way back with Dr. Rakeshtan and Dr. Nandi, we too published this paper that by doing the surgery and removing the strictures and stones, you can achieve what we call as the better control of diabetes and low use of the insulins in them. Yeah. And I think it's going to be further strengthened by the work which you are taking up. Thank you very much for your excellent talk, and we have Dr. David Grandad and Dr. Chawla Sab there. Thank you very much again for an excellent talk. Thank you.